No, sure. Okay. So we have to decide you ride and Ron.
Were you aware of the
Never can tell what kind of vehicle they have.
Now the guys that ran it were so helpful. And they, they did everything they could to.
Right. Oh,
Yeah, but it's just not.
Thank you.
Okay.
Yeah.
Can I sit with you? Because nobody at my table.
If you like, I can say a couple words about I'm not in an area like psychology where I see that many patients. Those kind of end-of-life issues are relevant. I can say a few words today about to convince the College of Physicians and Surgeons to give us some conscience protection.
I don't want to risk it.
Sure. Okay.
I'm a little bit paranoid, so I will.
Sure.
Our contingent from Canada, the idea was to be there to say no. It was the thing that I thought was it's terrible what's happening in Canada. Which was a big deal for WWA because there's a line
That's the thing about Southern Ontario, you're not so isolated here in Winnipeg. There's Winnipeg and you have to go a long way. Yeah, you have to go a long way to see something or to see. That's not very charitable, I know, but not that far. No, I have
So we just have this working.
So I'll be able to say, and this mic's hooked up, I'll be able to say we're not starting in 15 minutes.
Just tell us when you're gonna do that. Are you doing that right now?
Yeah, that's what I recognize.
Hold on. I wanna make sure you're live.
Very good. And also, so is this microphone, it's gonna work fine with us being this far away from you?
Yeah, it'll be fine. Yeah, I can turn it up if you need to hear, but we're all good for levels.
And, you know that Taylor can't have this podium.
Yes, we know that.
Yeah. So it's all live, we kick it? That's fine. Okay, so good morning, everybody. We're not actually going to start the symposium for another 15 minutes or so, but I am announcing a change in our schedule. And so what I'm going to do is, and so everybody should know I'm Alex Schadenberg. If you don't know I'm Alex Schadenberg, now you do. I'm the Executive Director of the Euthanasia Prevention Coalition. And those who are out watching this in the internet, and I know there's a few of you there right now, that on the schedule we received, we're changing it a little bit. We're going to have Amy Hasbrook, our president, go first, and then we're going to have our break. So that's going to be the change in the schedule, and then James Mahoney will be then right after the break. So this is a shuffle of people, but that's fine. It'll work really well. So not everyone's in our room yet here, so we're going to have a few more minutes of waiting, but all the speakers are here, etc. For those who are watching out on the internet, we will have a short presentation at lunchtime going on, so it won't be just watching people in the room eating food or things like that. And I think you'll find that this is going to work very well. We have a very professional film crew here, and I think this conference is going to go excellent for those who are here, but also those who are watching it on the internet. And I'm looking forward to this day. And we're adjusting for sound, and it's perfect. Very good. So if you know, we're going to be starting around 9:15. We have a few more minutes, and if you're watching on the internet, you know you have a few minutes to wait. Thank you very much.
Good to see you.
Now, how come, what's his name in the office?
His father is
Very close.
he's
It's only from their phone. He's doing what he's supposed to do.
he's doing what he's supposed to do.
Yeah.
down to about the North Saskatchewan River, and it kind of goes up to the seaboard. But it, yeah, like it doesn't take any, like the north west part of the province is in the archdiocese of Winnipeg, but yeah, like Whiteport, Fox would be the archdiocese. But yeah, it's just north of Edmonton.
Right, right. Quite a territory, though. Quite a,
Yeah.
and what town are you from?
I'm from Lac-Beauvais.
Okay. Robert Sherwood's son. This, Robert Sherwood.
Okay.
I think some of his poetry, some of his ballads.
These are my friends that walked out of assisted suicide already 18 years ago.
Oh, okay. All right. Thank you. The one with the son that's a police officer?
Yes.
Good. Good story.
Yeah, okay, I didn't know there was.
But they can contact you. Yeah, so it's already here.
Yeah, we wouldn't have to make it.
Yeah.
I think the law is great.
Well, there's lots of seats.
I was just afraid of walking in the camera. I'm afraid of walking in the camera.
That chair here, it's in the way.
Yeah, I'm gonna go upstairs and get a phone so I can take photos.
Yeah.
Maybe you'll end up using my newsletter.
I don't think so. I'm sure they'll bring some.
Oh, yeah.
Okay, so the camera is, Amy's gonna be down in a minute though, so it's fine. So for everyone in the room, we have breakfast at the back, so you should grab some food because we're going to be starting in a few minutes. And it's easier that way. So the other thing is that during the lunch break, we will have a short presentation too. That's to your, for you, but also of course for everyone. We have Dr. Larry Rados here with us, who will talk for about 15 minutes about the battle for conscience rights here in Manitoba, a political battle that they've won. So that's very important. Notepads here. Does anyone want a notepad? That's why one of them grabs the breakfast before we get started.
It's a beautiful sound, all the splash.
Just tell you.
Yeah, I can hear the sound.
Slide, does that work?
So yesterday, I did the same thing, like 40 days for like, I'm going Friday short, and I brought my
So ladies and gentlemen, my name is Alex Schattenberg. I know that most of you know me, so I don't have to say that too often. I'm the Executive Director of the Euthanasia Prevention Coalition. I'm very happy that you're here today, whether you're here in our room or you're here with us on the internet. There's going to be quite a few joining us on the YouTube link on the internet, so we're quite, looking forward to the fact that we're, how would you say, beaming out across the world. The first speaker this morning, as I mentioned earlier, was going to be Jim Mahoney. We moved him to right after break, and we're having Amy Hasbrook first. And the only reason for that is her presentation is a little bit longer, and we want to make sure there was time and there was no squeezing of time later. So we're going to have her now, and it is a very important presentation because she's going to be going through the regulations for the euthanasia law in Canada. And there's not very many people who have analyzed these regulations, and certainly Amy has. The other thing is, you probably know Amy already, but if you don't, she's the president of the Euthanasia Prevention Coalition, but she also is the director or president or leader of the Toujours Vivant, Not Dead Yet, which is a disability rights group that's been very active for quite a few years in Quebec, connected to the Council of Canadians with Disabilities. But she's been very active, and it's been a great working relationship. Amy's also a lawyer by training, and she lives, she's originally an American, but she lives in Quebec, and so we have her here in Canada with us for quite a few years. And Kevin's going to adjust the microphone hopefully for Amy and not me.
Anyway, and so without further ado, Amy's going to introduce her presentation to you.
Hi. I also want to welcome everybody on behalf of the Board of the Euthanasia Prevention Coalition to the 2018 Symposium. As Alex said, my name is Amy Hasbrook, and I have been living in Quebec, Canada for 15 years, but I was originally from the United States, where I became involved with Not Dead Yet, the disability rights opposition to assisted suicide and euthanasia in 1996. What I wanted to talk about today starts with the Carter case that was decided in February of 2015. And obviously we disagree with the ruling, and we think they're wrong. And there are several areas where we think they're wrong, but one of the more important areas is that they talked about feeling that there was not enough evidence to demonstrate that there could be a problem with assisted suicide and euthanasia. And by the way, I use the terms assisted suicide and euthanasia instead of the euphemistic medical aid in dying or medical assistance in dying, because in my view, we are talking about assisted suicide and euthanasia. And it's important to continue to use those terms because we don't want to use euphemisms. We don't want to hide what they're doing. We want to be straightforward about it. Anyway, so in the Carter case, they believed that there was a lack of evidence that there were any problems in other jurisdictions. And the court, as to the risk to vulnerable people, the Supreme Court agreed with the trial judge and basically quoted from her ruling by saying that there was no evidence that people with disabilities are at a heightened risk for accessing physician-assisted dying, and this is their direct quote. So the court also rejected the argument that unconscious bias by physicians would undermine the assessment process, which we also disagree with, and there was evidence presented on that issue, but the trial judge disagreed. The court said that there was no evidence of inordinate impact on socially vulnerable populations in jurisdictions where it was allowed, assisted suicide and euthanasia. And also they said there was no compelling evidence that a permissive regime in Canada would result in a, quote, practical slippery slope, unquote. So they were wrong, of course, but the problem is that the evidence that was considered by the first court, the court of first instance in British Columbia, she had her idea of where she was going, and she wasn't going to be diverted from her idea. And so the fact that they couldn't produce reports of the numbers of people who were euthanized outside of the scope of the program meant to her that there's no problem. So in the Carter case, next slide, in the Carter case, what the Supreme Court called for, they said the risks could be identified and very substantially minimized. So they're not saying that the risks of abuse and coercion and all that would be eliminated. They said it would be very substantially minimized through a carefully designed system that imposes stringent limits that are scrupulously monitored and enforced. So that's what the law and the regulations are supposed to do. And the court said it. So, next slide. So the Supreme Court, or rather Parliament, created a law that has loopholes big enough to drive a truck through. It allows people who believe that the person wanted assisted suicide to get a pass if they euthanized the person when they actually didn't want to. When they help, even a person who isn't a medical person can help with the euthanasia. There are just a number of loopholes, very vague language about it's to the doctor's opinion about whether the person's eligible. There's no requirement that there be actual evidence that the person have the irremediable medical condition. And then we get to the regulations that were passed to implement. Because the law essentially says what you need to do, and the regulations say how to do it. And the stated goals of the regulations are to provide transparency and foster public trust, to support the protection of vulnerable individuals, and to help determine whether the legislation is meeting its objectives. That's what they said that they felt their goals were. Next slide, please. What the regulations should do, if they were actually going to comply with what the Supreme Court said, is a lot more expansive. In order to impose stringent limits, for example, they would need to obtain an accurate picture of who is using the program, both the number of people who are using it and demographic information to identify who are vulnerable persons. We need to know who is using it and who is vulnerable. They need to ensure that vulnerable people are not being induced to commit suicide in a time of weakness, which is another quote from the Carter ruling. And we need to know that people are not being subject to external pressure. Next slide, please. More on what the regulations should do. And again, this is just to meet the requirements stated in the Carter decision. They should impose stringent limits that are scrupulously monitored. So let's talk about scrupulous monitoring. Obtain complete and detailed data on why people are asking for assisted suicide. They need to ensure that eligibility requirements are being met, that the people who are euthanized are eligible. And we already have evidence from Quebec, which has done a little more in terms of accountability of who's being euthanized and who shouldn't be. And they've already noted several people who are not eligible who are euthanized. Nothing's been done, of course, but they've noted it. We need to ensure that the safeguards are being complied with, that all these great safeguards that they're saying are going to prevent people from being abused or coerced or whatever are being adhered to. And we need the complications that can happen when assisted suicide and euthanasia are administered, either self-administered or by euthanasia. Next slide, please. So the phrase, we need to impose stringent limits that are scrupulously monitored and enforced. So what the regulation should do is examine the role of assisted suicide and euthanasia promoters in the operation of the program. Because the people who have pushed for euthanasia and assisted suicide have been very active, both here and in the United States, in engaging people with euthanasia, facilitating people's euthanasia. We need to know what they're doing, how much money they're earning from that. So we need to ensure the transparency and accountability in the program. We need to assess the effectiveness of intervention to reduce the numbers of assisted suicide and euthanasia. Because we still allegedly have a policy to prevent suicides, even though that doesn't seem to be applied to people with disabilities and people who are at the end of life. So if we want to have a suicide prevention policy, we need to ensure that suicide prevention services are effective. But we also need to look at the effectiveness of access to high quality palliative care and providing disability services and supports. We need to evaluate the impact of assisted suicide on the medical profession, and we need to track the impact of assisted suicide and euthanasia on Canadian society, because there are already changes underway. The definition of suicide is being altered to exclude euthanasia and assisted suicide. That needs to be noted. And we're needing to do this this is going to require vigilance, because supposedly in 2021, they're going to review the legislation. Now, that's what they say they're going to do, and we need to keep their feet to the fire so they do it. And we need to provide them the evidence that shows that there are problems. So this is the vigilance we have to maintain. We need to be on the developing the regulations, slide number 8. Developing the regulations, so those are what the regulations should be doing. When Health Canada developed the regulations, they engaged in a pre-regulatory process, which had unnamed individuals and organizations being consulted in developing the first draft of the regulations. I didn't get an email on that. None of the Council of Canadians with Disabilities didn't get an email. EPC didn't get an email to participate in that process. In fact, no consumer or disability rights groups were invited to participate. These were provider groups, doctors, administrators, etc., who engaged in the process of developing the regulations. There were no minutes of planning meetings, nor a list of who participated. And so much for their goal of transparency and trust. Next slide, please. The impact of the provider groups' input, just one example. Health Canada pushed back the deadlines for doctors' reporting, and also chose not to enforce deadlines if the request does not result in euthanasia within 90 days. The obligation to report it disappears. Oh, it didn't happen. So that is to say that if the euthanasia doesn't happen within 90 days, it didn't happen. That doesn't say what happened to the person. And that is one of the big problems with the regulations, is we don't know what happens to people unless they were euthanized. Next slide, please. In developing the regulations, we want to look at whether they were carefully designed, because that's what the Supreme Court called for. Every death should be properly and accurately documented. However, the regulations include no plan or procedure to determine when assisted suicide and euthanasia deaths have not been reported. So they're not going to go looking to see if people were euthanized and no doctor reported it. And they're not going to track down missing reports. If they know of a euthanasia that happened but the doctor didn't report it, they're not going to track down the report. Nor are they going to fill in incomplete information. There's no plan for that. Nor are they going to, do they have any plan to settle disputes over missing and inaccurate information? And again, going back to Quebec, because there has been a process for a few years in Quebec where the Commission des Soins de Fin de Vie has tracked what's happened. They said, I believe the figure was 37% of the reports that were submitted had incomplete information. That's almost 2/5, that's almost 40%. And they had to go back and forth with the doctor, fill in this piece, what was this information, blah, blah, blah. And some of the doctors refused to provide the information. Yet the federal government has no provision for doing this. No provision for collecting that information. Next slide, please. The information that Health Canada plans to collect is date of birth, sex, health insurance number, and postal code. Next slide, please. The information they should be collecting is, if we want to find out who are vulnerable people and what is happening, then we need to know whether they're being discriminated against based on race, religion, ethnic background. We need to know their income range and household composition to know if they are under economic stress. We need to know what kind of housing situation, whether they're homeowners, renters, living with family, hospitalized in long-term care, homeless, or in prison. We need to know this, but it's not there. We need to know what language they speak and whether they're getting their services in their first language. We need to know how long they've been ill, if they've been, or disabled, if they've been disabled since for all their life, like me, or if they've acquired their disability within the past 18 months and they're still in the grief stage. We need to know who their healthcare provider is, and has their healthcare diagnosis or treatment been delayed because of lack of accessibility. That's a very common thing that happens. We don't have an MRI that we can lift you into. The table doesn't adjust, so we can't put you on the MRI table so you don't get a diagnosis. Are the people's needs for help with daily activities being met? And if so, by whom? Are they being compensated? Are there problems with the person's living situation? Is the person being abused or coerced or pressured? And do they have disability-related expenses that are not being met? These are just pieces of information we need to know if people are vulnerable or if people are being pressured, experiencing external pressure. Next slide, please. Okay. Is eligibility for euthanasia reason enough for euthanasia? The regulations assume that being eligible for euthanasia is reason enough to die. And that's the basic premise of discrimination for assisted suicide and euthanasia. And we don't believe that having a disability, having a grievous and irremediable medical condition, and having suffering, quote unquote, is reason enough to die. Because the suffering comes from social and political choices that our society makes about how people with disabilities are treated. So, regulations don't bother collecting data on the characteristics of people who request assisted suicide and euthanasia. They don't bother collecting information on the condition in which assisted suicide and euthanasia requests are made. They don't request whether individuals are seeking assisted suicide or euthanasia due to social or economic stressors, or inadequate palliation, or other treatment problems related to their medical condition, or whether they're not getting whether they have existential issues associated either with becoming disabled or with the approach of the end of life. And that last is a psychiatric issue, a mental health issue that can be treated. But again, the regulations assume that if you're eligible, that's reason enough. And we know that eligibility is not enough. Next slide. The reason people give for asking to die relate either to disability discrimination, inadequate services, or mental health issues. And here are some of the reasons that people give. And we've seen these lists before. Loss of autonomy, unable to do favorite activities, loss of control over bodily functions, perceived loss of dignity, feeling like a burden, economic hardship, psychological or spiritual or existential distress, etc., etc. And note that unrelieved physical pain and distress are at the bottom of the list because in the Washington and Oregon reports, it's a fairly small number of people who identify those problems as a source of motivation. Next slide, please. We also know that the risks, according to the Supreme Court, the risks can be substantially minimized. But the data collected doesn't ensure that people asking for assisted suicide and euthanasia are free from external pressures like economic and housing insecurity, abuse and coercion, prejudice and discrimination, such as racism, sexism, homophobia, and ableism, and unmet needs like mental health services, suicide prevention, palliative care, or disability-related supports. They don't even try. They don't even look at that. Just a second. Next slide, please. Let's look at the eligibility criteria. They're supposed to be scrupulously monitored. But the regulations use really vague, use really vague language about that removes the responsibility from practitioners for ensuring that eligibility, the person is eligible and that there is compliance with safeguards. So they use phrases like, practitioners must give an indication of, and whether something's true or not. And sometimes that's used for a true or false proposition. Sometimes it's used for a multiple choice proposition. And that language is used 22 times in the regulations. So it's a little, we're not talking asking for specific proof or whatever. It's asking the opinion of the clinician rather than getting objective proof. Again, the clinician information must be provided if known. So that takes away the responsibility for finding out. And finally, practitioners must report to the best of their knowledge or belief. Again, taking away any responsibility for providing objective proof that something is true. And when you're talking about whether something is true, like whether they comply with the safeguards, that's important. The safeguards must be enforced. Regulations put the onus for enforcing the law on local law enforcement organizations. Though, of course, at the top it said, that they need to be strictly enforced and blah, blah, blah. The regulations actually say that monitoring is fundamentally distinct from a process that seeks to assess individual medical or practitioners' compliance with the criminal code exemptions. Investigating instances of non-compliance with the eligibility criteria and procedural safeguards is set out in the criminal code falls outside of the scope of the federal monitoring regime and is under the purview of local law enforcement. So they are washing their hands. And there may be a legal justification for that, but we're talking about a program where people are dying. And how can they morally justify that abdication of responsibility? So there's no system for informing local law enforcement organizations of violations, nor do local law enforcement organizations have the means, the expertise, or the incentive to investigate and prosecute violations. And we've seen this in Quebec. In both of the annual reports that Quebec has produced, there have been people who are not eligible who are euthanized, and nobody has done anything. Safeguards must be enforced. Regulations make no effort to determine if the safeguards and/or eligibility criteria are effective in preventing ineligible people from being euthanized or protecting people from being induced to commit suicide in a time of weakness. Next slide. Safeguards. Kill us, interrupt us. So basically, if the person is deemed ineligible at any point during the application process or the eligibility determination process, all of a sudden their data is no longer interesting or important and it goes away. The problem is that we know that there are people who are deemed ineligible who come right back and apply again with the same circumstances. They get a different doctor and they get a different result. It's doctor shopping. We know people do this. And if they aren't going to keep track of who's applying and who's asking for the third time to be euthanized, they're not going to be tracking the program. They're not monitoring. So those safeguards should be applied even if the person becomes ineligible during the assessment process. And they should apply safeguards before the eligibility determination process proceeds, including providing proof that the request was made in writing and duly signed, dated, and witnessed. Because like I said before, it's up to the opinion and belief of the doctor or the medical practitioner whether that happened. The person was informed and that they have a grievous and irremediable medical condition, of their rights to palliative care, and of disability supports. Again, it's the person's opinion. It should be recorded, and their evidence should be provided that the person was informed that they may withdraw the request at any time. And finally, and this shouldn't be finally, but it is in the regulations, when people have a communication disability, they need to have access to an effective and impartial means of expressive, I speak, and receptive, I hear and understand, communication. So in their regulations, I believe they use the word reliable. Well, reliable is like when your car starts every morning. You know your car is going to start every morning. Even if your car doesn't work very well, you know it's going to start every morning, that's fine. But if the car doesn't serve your needs, like if I had a car and it started every morning, that would be great, but I can't drive it because I'm blind. So it's reliable, but it's not effective. And that's the difference. Next slide, please. The regulations don't track the complications of assisted suicide. They don't track what happens to the lethal prescription, whether it's filled. Are the drugs stored securely? How long are they kept? Who has access to them? Are they subject to theft or resale, or being accidentally taken by children? it's like they say, here's the prescription, we take no further responsibility. And there is nothing to prevent a third party from giving the lethal dose to the person against their will. Like I said, that is a loophole that's in the statute. If the person believes, if the third party believes the person wants assisted suicide and euthanasia, even if they're wrong, no problem, no blame. And they also don't track information about complications of self-administration, like if the person chokes on the pills, if they vomit up the pills, if they wake from a coma, if they go into spasms or convulsions and don't die. They don't track anything, they don't care. It's like, it's not our, as we say in French, c'est pas mes oignons, it's not my onions. Next slide, please. They don't even track complications of euthanasia. There's no requirement to document the process of death, such as the time between injections, the drugs that are used, the drug cocktail, the onset of coma, the time between administration and death, and whatever complications that arise and what measures are taken to deal with them. They don't track that. And again, getting back to that earlier documentation, impose stringent limits, careful, I'm sorry, I can never remember the lines, but you saw it all. Finally, they don't track the role of assisted suicide and euthanasia proponents in the process, and I mentioned this before, but Health Canada does not track the participation in providing, to avoid the potential of proponents to persuade people who are perhaps ambivalent about assisted suicide and euthanasia. So if somebody, and this has happened, that people have called the EPC saying, I'm looking for assisted suicide. And the compassionate community care folks have said, really? Well, we don't do that, and let's talk about why you're wanting to die. And generally the person learns or comes to understand that it's not that they want to die, it's that they need help that isn't available, and compassionate community care and Alex give them support they need to get the services they need to not feel alone, not feel at the end of their tether. The regulations don't track how much money groups like Dying with Dignity are getting from donations and legacies made by people who choose assisted suicide for the services that may be rendered, like referral services, or showing up and signing things, or helping out, or being present when you go to appointments or whatever. They're not preventing proponents from taking on tasks that are linked to assisted suicide application and eligibility determination, like witnessing the signing of the application, making referrals, informing people of their end-of-life options, or filling out forms. We don't know how much Dying with Dignity is doing of that, but it would be a good thing to know because they have an agenda. And if they're playing an instrumental role with people who might be ambivalent, that's not good. Because ambivalence is a symptom of need for not death, but something else. For assistance, for support, for any number of things. A few final thoughts. We need to encourage the government to improve monitoring, yes. Like I said, in 2021, the program is supposed to be reevaluated. The law is supposed to be reevaluated. And probably the government is going to do everything in its power to avoid doing that. So it's our responsibility as people who are concerned about this to hold their feet to the fire, to prevent the government from just pushing off to the side. We also have to be vigilant. And I'm going to borrow a phrase from the current terrorist environment. If you see something, say something. If you see that a person is ambivalent but is being pressured, or is ambivalent because it's not really that they want to die, but it's that they're stuck in a nursing home, that's what we need to be talking about, because we need to do our own documentation. Obviously, the government's not going to do it for us. We need to try to get the government to do it for us, but since the government's not going to do it for us, we have to be the ones to create the evidence to present to Parliament in 2021, in 3 years, that says this has gone off the rails. We need to tell our stories, and Fatal Flaws is a great example of telling our stories. And we need to continue to do that. We need to work for improved services and support so people won't feel the need to ask. We need to set up situations so people aren't shoved into nursing homes against their will, and Taylor's going to talk about that this afternoon. We need to let go of the lies about shame and indignity that are associated with becoming disabled, becoming weak, becoming incontinent, having to use a colostomy bag. Shit happens, okay? It happens to all of us. When we're babies, shit is great. Whee! But it's something we learn to be ashamed of it. And people who live with disabilities learn that it is not shameful. We have to let go of the shame. And finally, I'm going to say something that I say to myself oftentimes, because I deal with depression, very severe depression, post-traumatic stress disorder, and lots of other crap. And this work is extremely difficult because I have to face every day the view that non-disabled people think it would be better to be dead than be like me. And even if they say, oh no, it's only about people with cognitive or disabilities or dementia or people who use a colostomy bag, no. It's like saying, well, you're not that black. We're all disabled. I'm disabled just like somebody who has a cognitive disability, just like Tracy Latimer. I may have different abilities and capabilities, but I am disabled. Tracy Latimer was disabled. We've just passed the 25th anniversary of her death. She would have been 38 if she had had access to good communications devices. Maybe she would have been here. Who knows? But what I say to myself is that if I can't bear to live with myself, then I need to live for others. Because, yeah, I do get feeling like I'm stuck. And it does feel really bad. So if I can't live for myself, I need to live for other people, because that's the way I can continue. It's the way I feel like I have meaning in my life, and the way that I hope that I can give other people a sense of meaning and purpose. Thank you. Does anyone have any questions?
I do, Amy.
Yeah.
So in 2021, obviously there'll be some sort of there'll be some sort of a formal
Not
thing.
necessarily.
Okay, well, I'm thinking that Alex will probably have something, or yourself will have something through EPC and Not Dead Yet. But who is there somebody appointed yet? Who is it? I mean, besides our MP or MPPs, who is the appointed person under this?
No, there's no one appointed. It's supposed to come from Parliament to review the statute after 5 years.
Under which particular department?
You would be the Minister of Health or the Minister of Justice.
Okay. So if we pressure them now for some sort of a formal process, is that
I
a
think
realistic thing?
now would not be the moment,
Yeah.
but what we need to do now is to gather information and document as best as possible what is going on. That's what I meant by telling our stories.
Sure.
We not only need to tell the stories, we need to write them down. And, Toujours Vivant Not Dead Yet does that. We have a weekly webcast where we talk about issues of assisted suicide and euthanasia related to disability. And that's sort of how we create an opus of information about the subject. And we need to build that body of evidence so that in 2021, when they do the review, because we've made them, we will have something to present to them that shows very clearly how the system has gone off the rails.
Mm-hmm.
And I think also presenting the flaws in their monitoring program will be very important to show that in other jurisdictions, the same problems have occurred, but there's no monitoring. So in other jurisdictions, when they get the reports and the reports say there's no problem, that's because they don't track missing reports. They can't track missing reports because they don't know they exist.
Right.
Thank you.
I was going to comment to that. I'm not trying to take your spot here,
Yeah.
but anyway, the whole thing about getting calls and people who have died, we don't have this information. We received a call from a woman, and her nephew had died by euthanasia, and he was 51. He was not terminally ill. He had had a head injury, so he had a serious head injury, but he was fine. He was physically fine. He was completely healthy in every physical way. He had gone to the local doctors. He was living in a major city, so it's not like he was living in a small town like I do. He was living in a major city. He went to the local doctors. They all turned him down. They said, well, you don't qualify. You don't qualify. You don't qualify. And then he contacted Dying with Dignity. They then sent him to doctors who were connected to them, and he died by euthanasia. So the question is, how could that happen that he goes to a whole group of doctors, not just one doctor, he's turned down because he doesn't qualify, and then he can contact Dying with Dignity and they will refer him, and suddenly he's dead by euthanasia? That's the big question. Of course, that data is not going to show up. What will show up is there will be somebody who was 51 years old who died by euthanasia. It might not even mention head injury.
Right.
But that's the data. That's the only data we're going to see.
Right.
And you'll have no idea that there is a potential serious issue here,
Right.
because that's not on the data.
As soon as he's determined ineligible, any information about him, any data gathered about him disappears. Poof!
Yeah.
So it's like he never existed in the system. It's like he never made a request. That's how doctor shopping is enabled.
Thank you.
Gordon, I have a question.
Oh, Gordon, you had a question?
Yeah, I'd just like to point out how important the work you're doing is, Amy, because you're coming from a standing start, because in time none of this has been talked about. In '92, with Sue Rodriguez, she wasn't at the end of life, she wasn't suffering, she was euthanized. It was done virtually publicly. There was a member of Parliament present. There was no criminal penalty for that. They did everything that they could to absolutely dare the government to draw them into court so that they could have a cause célèbre, and the government didn't do it. The government declined to do it. And if I understand the situation, no doctor has ever been convicted I'm not sure about charge, but no doctor has ever been convicted of anything having to do with assisted suicide going back in the 70s.
Yeah,
Is
that's
that
not
not quite right?
exactly true, but
many
it's
cases?
very, very rare that a
Yeah,
doctor
okay,
is
so it's
convicted.
close to being true. I guess it's a little bit of hyperbole.
Yeah.
The point being that there have been thousands and thousands of assisted suicides and
Right.
nothing has been done about it. So your work is absolutely essential because you're laying on the groundwork for exposing.
Right.
So those watching online, Gordon said Amy's work has been important.
Here, here.
Right, and I should say that it's not just my work, because we need all of us to collaborate in this. I mean, I'm only one person. I can find information, I can convey it to other people, I can communicate it, but like I said, if you see something, say something. If you think something's off, you know, call it.
I got a text from someone watching online, and the question is, if there is inadequate tracking of cases now, how do we currently know about the practices that do not comport with the regulations? Just people who happen to call EPC? If so, does EPC corroborate the accuracy of the caller? This is obviously a difficulty because
Yes.
to corroborate the accuracy of the caller would mean you have to go visit them, etc. You have to get them to write down. It should be, how would you say, when you have a legal signing, it should be signed off. And in fact, that's a good point, and that's actually what we should be trying to do, get it all signed off.
Yep.
But the other thing about the inaccuracy of the regulations, you're absolutely right, there is no follow-up, and so therefore it is, as Amy is saying, people have to talk about it, or we will never know.
Right.
And that is the problem with the situation, we'll never know.
Right, and that's why it's important to go through this process of analyzing what the regulations require and what they don't, to see what's missing, to see what they are asking for and what they're not asking for. Because unfortunately, we can't prove a negative, but we can show what should be there and isn't, to some degree. And we also have some information from the Quebec Commission des Soins de Fin de Vie, which tracks things a little more closely, because they have actually a comparison system. They get reports directly from doctors to the Collège des Médecins, and they get reports from facilities, from the hospitals and end-of-life services and stuff, hospices, and they can corroborate those data. But that doesn't exist at the federal level. And, you know, I mean, there are a lot of problems that I didn't mention today because I didn't have time, but one of the problems is that, sorry, I just drew a blank. There's no, when information is passed from the province to the federal government, it's passed as a body. So you may not be able to track down what happened within an individual case.
Right.
So it's this agglomeration, this blob of information. And you may not be able to track what happened to one person.
So I got a text from Dr. Paul Saba,
Hi, Paul.
and he says, is there any legal action that can be taken to challenge the laws based on concerns about eligibility and monitoring? The law is pretty loose on that, actually.
Yeah, I mean, that's the other thing, is that the law itself has some really big loopholes. Again, it's up to the opinion of the medical practitioner, what, you know, whether the person's eligible, whether they set safeguards are adhered to. So it's really hard to say that, you know, if the doctor said, yeah, my opinion is the person's eligible, it's really hard to challenge that.
So I was going to say two things. If you're watching the symposium, if you're here, we can send you the PowerPoint, because there is a lot of information in the PowerPoint from Amy, and other PowerPoints you're going to see. There might be another question yet. I was going to also say that we know the case of Dr. Kevin Stevens, is it the one in Oregon, talking about his patient who was depressed. And it's the same thing that in Oregon, his patient was depressed. Ken Stevens, yeah. That's right, and his patient was depressed and died by assisted suicide, even though he was the one who was called for the second opinion and made it clear that, you know, my patient needs help for depression, does not need assisted suicide, and in fact his patient died by assisted suicide. So we're not alone in this problem. Nonetheless, this is a reality that we have to recognize, that these safeguards are not designed to protect people going through a difficult time in their life.
Right.
These safeguards are designed to protect the physician who's willing to be involved with killing a patient.
Yes, and you know, the safeguards in the regulations and the safeguards in the law are not there. They don't exist to prevent doctor shopping. They just don't. And so as long as people continue to have a desire, they'll continue to ask more and more people, and they'll finally find somebody.
Any other questions?
Any other questions? No. Okay, thanks.
Okay, so we're going to take a short break now. For those who are watching from outside of here, we're going to take a short break. We'll be back in about 10 minutes or 15 minutes. And the second half, we're going to start with Mr. James Mahoney, and then we're going to go to Kevin Dunn. So don't leave us. You can leave us for a minute, and we'll be back in a few minutes. There's coffee at the back, and if the coffee's low, there's the coffee machine in the hallway, and then there's still cream back there. We have breakfast still there if you're hungry. There's some fruit there. And we might as well take advantage of what we have. We have a few minutes break, and Kevin's going to switch things over. Online, this was looking too far away. So Kevin's moving it over so they can see the PowerPoint better online. Yeah, you can.
You said Kevin.
No, I said Ben. You said Kevin.
Oh, yeah, okay, yeah.
No, but I think the point of it is he was the physician, the patient was distressed. I didn't get further into it.
Yeah, but the actual, the
Okay, so when you need me, we can set that up. Here.
Just tell me where to move things. It'd be better if we were higher.
We're taking a picture. Want to be in it?
No, it's all good.
So,
Can you just
here?
Could you go with where you were?
Okay. Oh, right, okay.
She wants to sign in the picture.
Yeah, that fits. So that fits that end.
Yeah. Should I?
This is as close as we can get. Just where we're going.
Higher.
Try it.
Beautiful. Okay.
No, if you want to put a chair.
It did.
Yeah. That's good. I'm gonna try something really fast. There we go.
Yeah, by doing that, she'll come up with
Kind of installable. But it's not the increase in the number, but it's not, the first day
now, because of space, did you want to move this forward and try to get again?
We just did.
and the thing is, the boxer, I've always give And sometimes we down in the bottom. Get in there.
It's not in, if we got the screen.
Sign over a little bit.
You can move it in behind, but the sound system is there. I can.
What it's done is normalize and it changes your way of thinking. That's what.
It's good.
The meaning of the doctor was really dream. And basically what but by accident, it happened that the patient passed. Now the difference is it's not an accident, it's a kill. And it becomes normal to kill.
I wrote an article this month about mature mind. And the thing about it is that there was, I don't know if you saw this, this article came out. Hospital sick children in technology. And they are working on basically you're supposed to report to the academics, the oncology. I mean, the report is supposed to be next year, or the end of this year. This paper from the hospital sick children
Left didn't jump. The screen went down. There was there's nothing on the screen.
No, I just started some questions.
And that's quite amazing when you think about it. Make the trains run on time. So it's pretty heavy.
Because we got to get started again in a minute. So how's it looking? It looks out, yeah. And then the PowerPoint's going to show better than now? Yeah, good. Okay, and are we, is it just showing that we're not here right now? Or can they hear me? They can hear me perfect. Excellent.
Yeah, that's right.
No, it is.
And then you can widen it even, yeah.
I can't widen too much. Yeah, that's all I got.
Push it back a little bit. Yeah, I mean, I've got an angle.
Well, it looks. Yeah. I wrote it.
It's just there. Okay.
Yeah.
No one's going to actually.
good? You ready to go? I am, and it's gonna be good.